Yes, I will read.
Okay, I'll
Yes,
call him Mr. John.
okay, Assalamu alaikum. The non-clinical consultation day. First scenario, the location, assessment unit, adult medical unit, patient 65 years old man. He's known case of stable angina, known case, diagnosed 7 years ago at James Cook Hospital. Type 1 diabetes, hypertension. He's presenting with chest pain, the vitals, systolic blood pressure 178 over 95, heart rate 70, temperature normal, saturation 99. The task is to take history and examine the patient. Okay, you can start now. Here you go.
Hello, my name is Dr. Ibrahim. I'm one of the doctors in the clinic today. I'm here to take to just to ask you a few questions, to examine you, and to ask you about your concern. Can I just confirm with you, are you Mr. John, 65-year old?
Yeah, I'm John. How are you, Dr. Ibrahim?
I'm fine, thank you. It came to my knowledge that you have chest pain. Could you just tell me more about that, please?
Yeah. For the last 3 months, I've been feeling this pains. It usually comes when I'm going uphill.
Okay. And I understand also you've been diagnosed with some heart problem 7 years ago. Is that similar to the chest pain that you've been having at that time?
Oh yeah. It is kind of similar.
Okay.
7 years ago, I
Um,
was diagnosed at James Cook with some heart problems, angina, if I remember correctly. And in the last 3 months, I'm finding this pains is coming back.
okay, I'm sorry for that. I will just come to the heart problem that you've been diagnosed with, but firstly, I will ask you a few questions regarding your chest pain.
Yeah.
I understand that you've been having this chest pain for the last 3 months. So, how frequent have you been experiencing this chest pain?
Whenever I'm going uphill,
And how frequently?
it's
Whenever you're going
difficult to say.
uphill.
Yeah, whenever I'm
That's
going.
okay.
Yeah, yeah.
Could you just tell me the side of the pain, please?
It's in my chest.
Is it in the center of the chest or other side of the chest?
No, it's in the
Exactly.
center. In the center.
Okay, and could you just describe this pain for me? Is it something wrapping or stabbing, something heavy?
It looks like heaviness. Yeah,
Okay.
you can tell.
Does it
Yeah.
go anywhere? Does it go anywhere else?
Um, to the back.
Okay. And could you just tell me, when you're having this chest pain, do you feel sick or are you being sick at any way?
No, not sick in particular. No,
Okay, and sweating with this pain.
no,
Okay, and do you experience this pain when you are at rest, like watching television or not doing an activity?
no.
Okay. Apart from like going uphill, is there anything makes it worse?
No, nothing to my note. No, I didn't notice
Okay.
anything make it worse. No.
Okay. Anything makes it better, like taking paracetamol or anything else?
No.
Okay. And in a score of 0 to 10, zero being no pain and 10 being the worst, how could you score your pain?
When it comes, it forces me to stop, to be honest. So maybe 8 to 9.
Okay, I'm sorry for that. Are you currently having chest pain now?
No.
Okay. Can I ask you, is this chest pain associated with any racing of your heartbeat?
No.
Okay. Do you have any cough?
No.
Okay. Any swelling in your legs?
No.
Okay. Any difficulty in breathing in any way?
When I have the pain, yes, I stop. But in normal circumstances, no.
Okay. And any difficulty in breathing at night that wakes you searching for air.
No.
Okay. Um, can I just ask you, apart from this medical condition that you've been diagnosed with, I mean the heart problem, have you been diagnosed with any medical condition that I should be aware of?
Um, I'm diabetic and I'm on insulin. And recently I had high blood pressure readings.
Okay. Um, I I will come to that. I will just ask you some few questions and I will come to your
Mm,
medical condition. Is that okay?
yeah.
Okay. Do you feel tired in any way?
No.
Okay. Any any loss of appetite?
No, 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 no.
Okay. Any lumps or bumps anywhere in your body?
No.
Okay. Any weakness in any part of your body?
No.
Any problem with your sensation?
No.
Okay. Any loose motion?
No.
Any tummy pain?
No.
Any problem with your water word system?
No.
Okay. Any joint pain?
No.
Okay, that's fine. And you told me that um, um, you've been diagnosed with the heart problem, and also high blood pressure and high blood sugar. Any other medical condition?
No, nothing I'm aware of.
Okay, and you've told me that your blood pressure is not controlled. Are you taking any medication
No,
for
my
that?
blood pressure is high a little bit recently.
Okay.
So, yeah.
Are you taking any medication for your blood pressure?
No, I haven't been started yet on any blood pressure medication.
Okay. Can you show me the list of your medication, please?
I don't have a list of medication, doctor.
You don't take anything. Okay.
No, no,
And
no. I don't have a list of medication, doctor.
okay,
I can
can
just
you
can tell you,
tell
yeah,
me?
on
Okay,
the top
that's
of my
fine.
head.
Yeah.
I take amlodipine, something like that, and
Okay.
um, bisoprolol,
Mm-hmm.
and insulin,
Okay.
and some
Um,
spray. It's been prescribed when I feel the pain. I can take some of the spray.
okay. And the spray usually relieve your pain, isn't it?
Yes.
Okay. Um, any allergy?
Oh, no, no, no.
Do you smoke?
No,
Do you drink alcohol?
no.
Okay. What's your job?
I used to be a postman before, and now I'm working in a library. So it's more kind of a desk job, but I do cycle on a daily basis.
Okay. And could you tell me how this chest pain affects your job and your daily activity in general?
It's not affecting my job, but whenever I'm cycling, I have to stop quite a few times when I'm heading back home because I live uphill.
Okay, I'm sorry for that. I can see that should be frustrating for you, and we definitely we were able to help you with that. Okay. Do you drive?
Yes.
Okay. Um, have you experienced any chest pain while driving?
No, 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 no. But I don't
Okay.
rely on driving most of the time. I'm usually active, so I use the car just to go outside of the town, but not
Okay.
inside.
Okay. Um. Okay, that's fine. And yeah. Okay, I will start examining you, and if I have any question, I'll ask you during the examination. Is that okay?
Yeah, please. Yeah.
Okay. And I'm sorry, could you just tell me if you have any like one of your family have a heart condition or heart problem,
Oh
or
yeah,
mainly heart attack?
my dad passed away because of heart attack, and my elder brother also had the same problem. Thank
I'm sorry for your loss. Please accept my condolences.
you.
Um, Okay. And just can I ask you, sorry, just a question. Do you have any swelling or pain in any of your legs?
No, 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 no,
Okay. Any history of clot before?
no,
Have you been recently traveled anywhere?
no,
Okay. And any fever?
no.
No. Okay. I'll start examining you by taking the observation. So all the observation, I think I've been
Yeah, as
given is
provided.
the blood
Yeah,
pressure and
yeah.
okay, yeah, that's fine. And I will feel for the pulse, all the thing, volume,
Pulse
character.
equal and
o-
good volume.
Okay.
Any
Um,
any special
any,
maneuver you're doing about the pulse?
any collapsing pulse?
Yes, there is a collapsing pulse.
Okay. Is it synchronous pulse? Is
No.
it okay? Any femoral delay?
You don't need to examine that.
Okay, that's fine. Can I just examine your JVP? Is it elevated?
The patient is sitting. You are not moving the patient to the examination table. Proceed with the examination whilst the patient is sitting, please.
Okay. Um, I'm sorry, I would like to. The patient should ideally be lying in the examination table.
No, please
Or
proceed while the patient is
okay,
sitting, please.
that's okay, that's fine.
Yeah.
Any pallor or jaundice in the eyes?
No,
Okay, any mouth soreness, any angular
no.
stomatitis, any okay, cyanosis, no. Just examination. Okay, I will examine for heartbeat. So the side of the heart, of the heartbeat, is it in place?
Is it the apex, you mean? Yes.
I'm sorry, heart apex. Okay, palpable B2.
No,
Any thrill?
no.
Okay. Um, um, or examination of the different heart areas.
What areas exactly you are listening
Okay,
to?
mitral area.
Normal,
Um, left lower prosternal, tricuspid,
normal,
pulmonary,
normal.
aortic,
You are
second
hearing a
aortic.
murmur
Okay, in which area? Is it the second aortic
in the
area or first
aorta,
aortic?
in the first aortic area.
Okay. Um, the nature of the murmur.
It is
So I will
not.
compare with
It's
the
not an
pulse. The
ejection.
systolic dias. Sorry,
It is diastolic murmur.
diastolic murmur. Okay, that's fine. Um, okay. And I will examine for lower limb edema.
No lower limb edema.
Okay, base of the lung, can I inspiratory crackles?
No.
Okay. Um okay, that's fine. Um could you just tell me your concern, Mr. John?
Well, I'm concerned about the me having the same fate as my father and my brother. To be honest, I know that I've been diagnosed with angina before, so and it runs in the family. So I'm afraid that those pains are sign of deterioration of the condition. I tried to
Um
keep myself active all of the time, to be honest.
2 minutes left.
okay, I do really appreciate your concern. After asking you the questions and after examining you, I'm just concerning that you might be having the same heart condition or even like
Mm.
worst like version of this heart condition. I'm sorry to tell you that, but you've been having affection of the blood supply to your heart, and that caused you the chest pain 7 years ago. And also, I'm concerning that this problem is happening again. And also, I would like to exclude other condition and other possible cause of the chest pain, but the top cause in my mind now is related to your previous heart disease. So I would like to keep you in the hospital to run some blood tests and also to do some workup and to give you the appropriate treatment after finishing our workup. Is that okay with you?
Yeah. Any advice, doctor, for me, for my lifestyle to prevent the deterioration?
So yeah, basically, for the health of the heart, we usually advise patient upon their diet, okay, like to stick to diet with low sugar, low salt, and high fiber, and also to
Time's
exercise
up.
but with limitation. Sorry.
Time's up. No, no worries, no worries. Thank you, Dr. Ahad. You've done so well. I didn't mean to interrupt your chain of thoughts, but this is how they do in the exam. They will stop
Yeah, that's
you
fine. Yeah,
at
I
exactly
agree with that,
15
to be
minutes.
honest.
Yeah,
Exactly. Okay.
yeah.
You can start now the examiner question, Dr. Ahmed.
First of all, can you summarize, please, this case for me and present your finding?
Okay, so 65-year-old with past history of a stable angina 7 years ago presented with chest pain.
Mhm.
It looks like like ischemic heart pain with like typical heart chest ischemic heart chest pain symptoms. It's in the center that increase with activity and radiating to the back. Sometimes associated with shortness of breath. He have a positive family history of heart or of like similar heart problem in the family in his brother and father. There is no risk factor for heart disease like smoking, alcohol.
What's your finding, doctor?
In the examination,
Yes.
there is collapsing balls. There is diastolic murmur in keeping with aortic regurgitation. Um, I think this is the positive finding in the examination. Yeah.
Okay. And anything else you would like to add?
In terms of findings, um,
It's fine.
uh,
Um,
I can't recall anything else.
no, thank you. What's your main differential in this case?
Okay, so my main differential here is firstly could be the recurrence of stable angina. Could be other spectrum of acute coronary syndrome like unstable angina, but not in favor that the patient is not having chest pain at rest. And we could in the context of the central chest pain radiating to the back, I could also think of aortic dissection, but not in favor of that is the nature of the chest pain that is increasing with activity that is going with ischemic heart disease. And the patient also is stable vitally. Um, I will add um, pericarditis in the list in the like list of the differential, but it's not top differential to be honest.
Why you've chosen pericarditis in your differential?
Um, well, in the context of the chest pain, it's not typical to be honest. The side
Mhm.
of the chest pain and it's more ischemic, but um should be investigated for also.
Okay.
I haven't asked. I'm sorry, I haven't asked about the increasing chest pain with leaning forward. I should just ask this
But
question.
the patient didn't describe that, but have he had anything in the history? Could it be suggestive of that?
No.
Yeah. Okay. Anything you would like to add to your differential?
Um, Maybe musculoskeletal chest pain.
Okay.
Um,
Um, you've mentioned that this gentleman might have features suggestive of aortic regurgitation. What might be the cause in this case of his regurgitating aorta?
Aortic regurgitation. Okay. Um, in this case specifically, I'm not sure about the aortic regurgitation cause. Um,
What's the causes of aortic regurgitation in general?
but it might be related to, can be associated with aortic dissection, can be um, um, I can't recall it in the top
Thank
of
you.
my mind.
Thank you, Dr. Ahmed. Thank you. Thank you very much. Um,
Okay, done,
Dr.
Dr.
Qasim.
Omar.
Yes.
Okay, can we repeat the differential from Dr. Ahad and from you again? Then we will comment. Okay, Dr. Ahad, please give us three in order. Sensible differential for this case.
Okay. First differential could be stable angina. The second differential could be other spectrum of aortic of acute coronary syndrome, like unstable angina.
So the same
Um,
recurrence
okay.
of ischemic heart disease or acute coronary syndrome. Okay, coronary artery
Um,
disease, right? So
yeah.
you meant for the first as a coronary. What else? The second?
Um, Valvular disease,
Valvular.
aortic
Perfect. So this
regurgitation.
is
Not
the term, valvular heart disease. Okay. And in term of,
Uh,
as you said, aortic regurgitation. The third,
the third, I think I will put pericarditis. I'm not sure to be honest, but I can't
it's
recall
not on the
any
differential.
differential as
You f
aortic dissection could be one of the differential here. In the context of the chest pain that is radiating to the back.
okay, but you have to
Um,
have evidence for pericarditis. So you can mention myocarditis. Okay, if more correlated to the chest pain of heart disease or clinically chest pain or typical chest pain. Pericarditis difficult in presentation in this way, so you will have different character. I will talk about this before Dr. Omar will comment now. Then I will talk about that after his comment. Okay. Well done, Dr. Ahad. Dr. Omar, you can speak now.
Uh, Dr. Ahad, thank you very much for standing for those questions. But to be honest, those questions have been asked to me personally, so I'm just reiterating them. First of all, in your history taking, in the scenario, they have mentioned the diagnosis for you to use. So when you're asking him about what makes the pain better, you can use the GTN because he's known diagnosis of angina, so he will be given a GTN. I would expected you to address the background problems very early because they are a modifiable risk factor of any heart disease, diabetes, high blood pressure. His blood pressure haven't been addressed yet, and the in the examination, what you've missed, as I did in the exam, to be honest, is the systolic and diastolic, and they wrote it this way. You need to present it that there is a wide pulse pressure on to the examiner when he asks you what else in the patient signs that you can add. Um, uh, for the differential For your differential, you started by ischemic heart disease, the second aortic dissection. The pericarditis, I don't think pericarditis would fit here um, in the differential, to be honest. Musculoskeletal is reasonable to state, but it would be lower in your differential. Aortic stenosis could have been added earlier given the history. Ischemic heart disease and aortic stenosis, aortic regurgitation, because the patient has clinical evidence of that. Mixed valvular disease. So those are the valvular diseases that can the patient have. In your history, you ask too much, whilst the case is straightforward. You don't need to waste your time. You went a little bit argumentative when the examiner told you not to move the patient. In reality, they ask you not to move the patient and complete the examination on the chair. So you need just to examine the heart, the general physical and the heart, the chest, and the lower limb, nothing else. This case has had bruises on the hand. I know it's difficult to acknowledge that in online simulation. If you've seen the hand, you would ask the patient why you had these bruises in real life or in a real exam. But sometimes from the stress, you might miss that. But I'm not confident that you have missed the bruises on his hand. One thing you didn't ask about is that he had lost consciousness or not. You've asked about dizziness, yes, but if you are taking a history from in ischemic heart disease, before examining the patient, you could have think of both either ischemic heart disease or aortic stenosis. Both do have exertional chest pain, but aortic stenosis can have exertional chest pain and syncope also as well. Um, this is pretty much the everything. I would appreciate if you avoid the ums and ahs a lot. You can stop and then talk instead of saying, this would give a negative impression about you from the point of view of the examiners. Did I miss anything, Dr. Bassem?
Yeah, I will comment on the clinical communication, but I
Yep.
think for the case, you covered the part of exam related to your case. So the differential you want to say here, again, acute coin syndrome, right?
Yes.
Valvular heart disease, either isolated or mixed. And the third is musculoskeletal, isn't? Is it what you want to say?
Yes. Yes.
Okay.
Dissection. I meant before
But
musculoskeletal.
dissection will not be as a chronic one.
Yes, of course.
Dissection will be presented as acute, and I don't think the patient even will tolerate the pain of dissection. It's
Yes, of course.
tearing pain, right?
Yeah.
So the patient will even he will not tolerate the pain to the extent he will stay at home. He will present to the emergency, not to the clinic. Or I think this patient
Yes.
acute medical unit, right? Adult or acute medical unit.
Yeah, AMU, yeah, acute medical unit. But
Acute medical unit, yeah.
yeah.
So it could be if he presented within minutes or hours, you can say aortic dissection. I don't know the onset of this pain, for how long it was.
This pain has been worsening in the last 3 months every time with with exertion. The patient is physically active, so the pain comes not while he's walking, but with cycling.
Mhm.
So if he walks, it's fine. If he cycles, then the problem is evident.
So it's typical chest pain.
Yes.
Okay, so I will talk about the clinical history or taking history from Dr. Ahad, what she missed and what she should do in the next time. Actually, it was good to start the analysis of the chest pain. The radiation, I think you asked Dr. Ahad, right? You asked
Yes.
about the radiation. Okay.
Yes.
What improve, what decrease the site, even the scale, which is very important to ask and to offer painkiller whenever the patient is having scale more than 5. I think Dr. Ahad covered all these things. Then the constitutional or the relevant system first. She asked about leg swelling or any short of breath, which is also related. So the respiratory always similar and will be relevant to the chest pain. Whenever you have chest pain, try to ask about the chest symptoms. Don't forget to ask about awareness of heartbeat, which is already have been asked by Dr. Ahad, which is perfect. We'll
Yes.
go to the constitutional. Dr. Ahad fragmented the constitutional. She didn't ask all the question of constitutional. She asked about lumps and appetite and weight. Later on, she remembered the fever. So I prefer to ask all the questions collectively at once. Don't fragment the systems.
Okay. Yeah. I think
So,
it's in.
so أيوة طيب
Yeah.
أكمل. Yeah, sorry, Doctor. I have interruption here. Sorry. Okay, I will continue, sir. Then you can comment after that. The other things I wanted you to do, the past medical history, even the main differential or the top differential of you, the angina, you don't know what happened with him. 7 years ago, what happened exactly? He didn't tell you. You didn't ask as well. Did he have the cath lab, stenting? You don't know, right? It's very important to know. Right, Dr. Ahad? Correct me if I'm wrong.
But yeah, I haven't asked about that because it was a stable angina, so it shouldn't be any interventional procedure. I mean, if
It
the
was
patient's been
stable
having,
or, oh, sorry, it was stable angina. Okay.
yeah,
So, I mean, yeah, basically he will be on medication only, right? Yeah, okay. So
yes,
forget about it. But at least to know what exactly happened with him, how he was diagnosed, and any medication started. And you ask about medication. You didn't ask about the compliance to the medication. Is he compliant on this medication? I mean, for all hypertension, no, newly diagnosed hypertension. So you will ask about the diabetes, insulin. Is he compliant on the insulin? What the importance of this question, Dr. Ahad?
um, so yeah, I think it's an important question. Basically, if he's not compliant on
Yes,
his
exactly. If
medication, that will, yeah,
yeah,
will be
it
discussed
will
on.
affect his the even the condition. If he has diabetic, uncontrolled diabetes or poorly controlled diabetes, the patient will have atherosclerosis, dyslipidemia, and all of them will be trigger for ischemic heart disease or coronary heart disease. So you have to ask about this thing. Any surgery, any allergy, are of all these questions are important. Back to the other medication and the medication for angina. What this patient kept on? Is he on bisoprolol? Is he on aspirin? You should know. He should be on antiplatelet or anti-ischemic medication, right? Does he started on or did he started on? You ask him about the medication list. He said, I don't have medication. But you can ask him, enumerate for me more. You didn't
Yeah, he mentioned
confirm.
that.
Is he on aspirin? This patient was on aspirin.
No, he wasn't. He
He,
he
wa-
told
he
me the
wasn't.
medication. Yeah.
Dr. Omar, is
No,
there
I
any?
did. No, no, no. He wasn't on aspirin.
Okay, do you think it's important to be kept on aspirin?
Yes.
So there is something missing in the history or in the management plan from the previous diagnosed angina, right? Anyway, let's continue. The systemic review here, even it was fragmented. You ask about headache and tummy pain, loose motion, water work, muscle pain, but not in an order. The endocrine, you miss also intolerance to any weather. The hypothyroidism or hyperthyroidism, any thyroid disease could be here as a association with the diabetes as autoimmune. Could be. I'm not saying, but you have to ask even once only to rule out any thyroid disease. I'm not saying it's defective. No, it's I mean to be perfect. Okay. Back to the skin rash. He said there is skin problem here. What was them, Dr. Omar?
It
You
was
meant
it was bruises
yeah,
in his
bruises. So
hand
yeah, yeah.
because a
So
fall he had.
yeah,
Which I'm sorry, yeah, continue.
yeah. So I mean, it's some skin changes. It's not skin rash, but some skin changes. You might ask more details, systemic history, or systemic review questions. So he might explore that. Anyway, back to the fall here also can make sense if you ask about any dizziness or feeling dizzy while standing from sitting position. And the other neurological question you ask about only headache, I remember, if I can say. Other than this, the family history, whenever he mentioned about his father death, what age did you ask? And what the
Ne-
importance? Yeah. What do you think the importance of the father death at what age?
Um, yeah, I got your point that this could give a clue to for example, other like familial causes or familial risk factor like hypercholesterolemia. I think you're meaning that, but I don't
Perfect.
know if that could add to my history or to differentials.
Yes, it
So
can add. I will tell you now. But in other presentation, if for arrhythmia, for example, right? Hergada or other arrhythmic disease which is running in families, but not in this scenario. I mean, in general. I'm not talking about in particular here, okay? So, in general, whenever you have family history of death, try to know at what age. It can give you a clue, okay? Then let's go to the family travel. You ask all this or any system affection, okay? Give me a second only. Hold on. Yeah, sorry for interruption again. Okay, the other things here at the end, do you smoke? You ask good question. You ask about driving, and when you realize sometimes it's not affecting your history taking, you corrected yourself. Do you think the chest pain affecting your driving? Which is perfect question. It will give you good impression to the examiner time the question appropriately, even it was not related, but you kept it or you manipulated to make it related to the symptom. So if he has chest pain while driving, it's very important to stop him, which is good point for the welfare. The examination you did great about the full heart or cardiac examination, and I think the patient should be in the couch because the aortic regurg will be diagnosed with sitting forward in the second aortic area. And of course, the other murmurs, you have to roll it out. The apex detection, the pulse, the synchronized, even the delay from femoral to radial. It's important as well. Some patients will have phacocytoma. And I agree with Dr. Omar. The wide pulse pressure is something to be noticed in the paper, and you have to write it as a clue. This patient is having wide pulse pressure. I should present and I should mention to the examiner that I noticed that here or his heart or his pulse pressure is wide. Why? What the importance of this? You can say this is give me a more clue about aortic regurg, right? And it's also correlated with his wide pulse pressure as a collapsing pulse while doing examination. Okay. Anemia also you can mention as a differential if you have high pulse pressure along with chest pain, short of breath, exertional dyspnea. Anemia is available as a differential here, right? What do you think, Dr. Ahad?
I think as a presenting complaint of chest pain,
Mhm.
I wouldn't include anemia.
Yes, I
Um,
agree, but it's not as a presenting one. But if you have pallor in your examination, you can add it, but it could be a trigger for your patient symptoms. Anyway, it's not fitting today about our presentation. What you said, it's okay apart from pericarditis. You cannot say pericarditis unless you have history of infection, right? Sore throat or upper respiratory tract infection followed by this. So you can say this is viral pericarditis. Or what other similar condition to pericarditis related to his history, but it will be in a close window of symptom. What you call it? If you have patient with chest pain after angina, what we call this syndrome?
Chest pain following angina, or I'm sorry,
Yes, yeah, angina followed by chest pain. Anyone
angina is a
knows?
chest pain.
Yeah,
What do you
chest
mean by
pain,
angina follow?
angina. Then patient present after 3 weeks later on. He presents with
Dressler
Drizzler,
syndrome.
Drizzler.
Dressler syndrome.
exactly. Yes, this is what I want to say. Dressler syndrome.
Yeah, but at the time being,
Okay, yeah, but this 7 years ago, so you cannot say
yeah.
this is Dressler syndrome. Anyway, I want to just
Um,
raise this
to
issue
be
as a
honest, I'm
definition.
I'm
Yeah,
I'm not even convinced with the diagnosis of pericarditis. I haven't asked the
yeah, yeah.
well, I haven't asked by like
Sometimes we
chest
have to
pain when leaning
fill.
forward, but
Yeah,
obviously the patient is
exactly.
not having these symptoms because it's only triggered by activity. But I haven't found any other differential diagnosis of it, to be honest. But
Yeah,
yeah, it's not keeping with pericarditis, to be honest. Just one question about the family
yes.
history of at which age. I think this will be relevant in this case. It wouldn't make any difference because the patient's already been diagnosed with a stable angina several years ago, and even if he had like a father with heart attack at young age, it wouldn't change my management. I mean,
It will change the management.
sorry.
It will change the management in terms of if the patient is presenting to AMU, Dr. Ahad, and his father died at age of 50, at age of 70, for example, and the patient is 65. So you will ask for expedited or accelerate the investigation for this gentleman, given that he's approaching the critical age where his father and his brother died, for example. So it won't affect you differential. Yes, I'm 100% sure. And you wouldn't, I don't believe that we will be negatively marked if we didn't go through that. But the taking listen from what Dr. Bassem is saying is asking the age of this, in this case, it is relevant. You might ask the patient to be admitted to expedite the investigation. For example, if you found that
Yeah, exactly. What investigation, Dr. Omar, she should add?
Uh, first of all,
And
starting, yeah, I'm sorry, you want
okay,
to say?
yeah, I want to ask Dr. Ahad. Okay,
Okay.
I will just make it more better, clear, and clarify it more. Dr. Ahad, what do you think if this patient has two family member of cardiac death, sudden, at 40s, and the father as 50s? At what do you think you can add as a differential or the cause of cardiac death?
Um, yeah, if you mean genetic heart disease like maybe Hookham or
Coronary
um
artery disease, not HOCM. Coronary artery disease.
um maybe as a risk factor
Familial.
hyperlipidemia, but
Perfect. This is what I want you to say. Yes. Familial hyperlipidemia. So they might have a lot of family members, they have cardiac death because of coronary artery disease. And of course, you have to admit this patient if they have this risk. And you can add also to your investigation. What do you think?
Fine.
if you yeah I got to your point, but I mean the patient himself is not having the symptoms while he's young, so definitely the patient is not having genetic condition. Have you got me?
Yeah, yeah, it could be presented earlier and younger than this.
Yeah,
This is what you will say, right? But you will add lipid profile, full and detailed lipid profile,
yeah,
plus
I will do a little bit
genetic.
profile.
Yeah,
Yeah,
this is what I
regardless.
want also to say.
Yeah.
Yeah. Do you think this is okay, Dr. Omar?
Yes, so for the investigation, you would start
Yes.
investigating the patient from the bedside,
Mhm.
moving to the bloods and then the specifics. The specifics in this patient would be in the bloods hemoglobin A1C plus lipid profile, and then you don't need to mention troponin or any cardiac enzymes, but you
Why?
can
Why you
because the
couldn't
patient
add?
doesn't have because the patient will have doesn't have active chest pain at the moment. So measuring the troponin is not twice. This is what the examiner replied to me when I mentioned this. The second is the for the specific CT coronary angio, after cardiology referral, of course. If you ask the patient about the nature of the admission when he had at James Cook 7 years ago, he would have told you that he had a stent, for example, or he doesn't have a stent, as you've added. So then this is the full panel of investigation would be usually like this. Did I miss anything, Dr. Bassem?
Okay, yes, I think this is good for the investigation. The management plan, of course, admission. I agree to admit this patient, although no chest pain ongoing, but I have to rule out other triggers that can help to diagnose this patient, why he had this. By the way, if you suspect aortic dissection, this patient immediately he should
CT
be
coronary angio,
moved. Yeah, CT aortograph.
CT aortogram, yeah.
Yeah, if you suspect aortic dissection, you mentioned chest pain, radiated to the back, severe, all this character will give you a clue. Could be aortic dissection. I should admit this patient immediately to the CT aortogram and I will call for the vascular team. Okay, don't forget the multidisciplinary team approach, Dr. Ahad.
Yes.
Okay, anything else you want
The
to add,
two
Dr.? Yeah, sorry. Yeah, sorry.
No, two question I've been asked about in this case. Why
Yeah,
do you
yeah.
think that this patient has aortic regurgitation?
Yes.
And the second thing that they've asked me not to move the patient to the examination table, to be honest.
Yeah, they don't want to make it clear
Yeah.
because whenever you move the patient, you can do the sitting and semi-sitting position examination. But here also it will be good to let the patient sitting. You will catch the early diastolic murmur while the patient is sitting
No, here the
already.
patient was sitting on a chair, so they
Yeah,
didn't
yeah,
they did ask not to move the patient on the examination table.
yeah. Examination mean
Um,
the couch, right?
the couch or the examination table or whatever it is called usually
So
when you
you
ask the
diagnose
patient to
the
lie
early
flat.
diastolic murmur while sitting.
Yeah,
Sitting
yeah, yeah,
forward.
yeah, yeah.
So it means in this position, okay? Okay, perfect, Dr. Omar and Dr. Ahad. Can you suppose the scenario, Dr. Ahad, for Dr. Omar?
So, but
And
why this patient can have aortic regurgitation? This the question. This was
this
the
is the
question to
question,
me.
okay? And Dr. Ahad answered this question or no?
No, no, I didn't ask this question to be honest because I'm not sure about the answer I gave.
Okay, what do you think? I will ask you the same question.
Uh,
W-
so what I said is that because the patient does have not yet had formal diagnosis of of hypertension, but
This is one.
his blood pressure could have been uncontrolled for a while, so this could have affected his
Perfect.
aortic
So
fluid.
this is one of the reasons of aortic regurg, the hypertension itself, right?
Yeah, they asked me what else.
What
So
else? Yeah, I will ask you what else.
I said it could be at the level of the aortic valve itself, calcification given the patient age. They said what
Okay.
else?
Yeah, perfect.
And
So
I
degenerative
mentioned,
change.
yeah,
Degenerative
and
change. Okay.
I mentioned bicuspid aortic valve
Okay, but it could be presented earlier. The bicuspid
earlier.
will present earlier. Okay, at
Yeah.
younger age. What
And then the
else?
time has finished. So I
Okay,
moved to the next
what
stages.
you want, what you can add, Dr. Omar, to your causes. By the way, you
So
can put it not only in this case, in any valvular heart disease, any
the
regurgitation.
rheumatic,
Exactly.
the infective endocarditis and the rheumatic fever,
Infective
yes.
endocarditis, rheumatic heart disease,
Uh,
and
um,
as acute.
autoimmune disorders
Okay,
as
connective
acute
tissue, collagen, as acute, yes, as
connective tissue
acute.
disease.
Okay,
Um,
as acute. Always remember the MI. MI can leave ischemic heart, and the ischemic part of the valve can lead to the regurg, particularly the mitral regurg. It's very
I mean,
important to mention.
yes, but yeah, but um, it wasn't the mitral, so I
Yeah,
I didn't
even
think of
even
that.
yeah, even you can mention or traumatic trauma. patient might have trauma can lead also to aortic arch, right? So all of them are valid as a differential. If they want more, I want to make more differential and more causes as a discussion, okay? So you will know how to answer the examiner. Don't be stick to one or two causes. Always they love to hear more about the causes or the differential, okay?
Hmm.
Okay. Dr. Ahad, did you send the scenario?
Yeah, I sent it.
Excuse me, Dr. Basim.
Yeah, okay. Let me read the scenario first. Sorry, doctor, and then I'll be back with you. You are the medical registrar, 30 years old male, Mr. John. His wife noticed a change in his eye appearance. Please see and advise. Perfect. It looks nice case. Let's go. Yes, I'm so sorry to one I interrupted. Doctor, you can continue. Hello? The
Yes,
doctor who was talking. Yes, please. What you want to say?
I want to ask if from the start the case is well known as anginal pain. Should I put differential also?
Yes, definitely. You have to put it as one of your differential, not only one, the first and the top. Why you can say that? Sometimes the patient is not compliant to the medication. Other times, patient will be on the same lifestyle, erratic lifestyle, smoking, alcohol, or diet itself. So these two reasons can be very strong hint that this patient could be represented again with the recurrence. The non-compliance of antiplatelet could be the reason. Patient is not taking aspirin or Plavix. He might have stenting before, stent to his coronary, and thrombosis happen, right? Always they want you to put a differential that makes sense. This is one of the very important differential. I like when Dr. Ahad said recurrence. You have to put it. I should think about something recur back. Okay.
Shukran, thank you.
Okay. Thank you. Very nice question. Thank you. Dr. Marwa, sorry, what was the cause of bruising? Did he had any other bleeding site? Okay, good question, Dr. Omar. Any cause of this bruising or just distract?
Hear me? He had a fall while he was working in the
Okay.
garden. He didn't lose consciousness or anything when I asked him. When I saw his hand, I asked him why he had those bruises. He said, I was doing some gardening and I fell on my hand. So
So traumatic one.
yeah.
But it can be making sense if this patient on warfarin or anticoagulant and he has mild or minor trauma, and you can say this is another differential of this bruises. Okay, this is for Dr. Marwa as so it's better and it's very important to explore more why I have this with that. And I discovered this. The examiner always like whenever you notice something on the patient and you present it. I noticed this patient is having injection mark. I noticed this patient is having bruises. I noticed his eyes looked like that. He has pallor. He has jaundice. What you inspect, they like more than what you hear or what you palpate or what you percuss. Okay, they are saying the good doctor is good observer. The one who can observe will be a good doctor, even without, or sorry, not without, but with before the examination, before doing the examination steps. Whenever you do inspect well, you will be good in other steps of examination. But what you miss, if you miss something in the inspection, it could be very harm to the mark because you didn't catch the things around or the things in the patient hand. Even cannula, if you find patient with cannula, it's okay to say, I noticed there is cannula in his hand. Okay. Any question from others? Dr. Ahad, you want to add any comment?
No,
Uh,
thank you.
Okay. Anyone want to
I, I,
ask?
I
Yes.
want to ask, this is as a long case, it is supposed to give a diagnosis from the start or just without a diagnosis to reach
Sometimes they put it as a differential for differential. Sometimes they want you to give a clear diagnosis. Sometimes they want to hear the most important and very dangerous differential. Like here, for example, I want to roll out aortic dissection whenever I hear the chest pain character going with the aortic dissection. So they want to hear that I want to admit this patient to do aortogram. Okay, this is the most dangerous in this patient if he presented in acute state. No, I am talking about patient with chronic presentation. So I want to roll out coronary heart disease. The patient come with chest pain, which is worse with the exertion. He had some dyspnea on exertion. Or I want to roll out, for example, the myocarditis if he has history of infection. So according to the history and the finding in the history, you can put your differential in the order the examiner needs.
So
Okay?
I have to exclude the dissection by history
No,
is enough.
no, I'm not saying in this scenario. In
Uh-huh.
this scenario, it wasn't as a clear going diagnosis with aortic dissection. But if you have a case with the chest pain, mainly
Yes.
central, radiate to the back, this is a clue for aortic dissection. I could say on the top of my differential, and I want to roll it out, aortic dissection. Particularly if the patient has chest pain within hours. Okay.
Okay, thank you very much.
Okay. Most welcome, Dr. Hasni.
Yes, doctor, I'm asking regarding this cardiovascular cases. I should do
Yes.
a full cardiovascular examination, right?
Oh yes, definitely.
Yani for this example, I will start from the hand. I will see the sign of infective endocarditis,
Yes.
especially if the
If
patient has valvular heart disease. Then I
perfect.
will do even the chest, the cardiovascular in full examination. I will see the patient. There is signs of infective endocarditis. There is signs of heart failure. There is signs of pulmonary hypertension, and I will mention
Yes.
that in the
Yes.
in the presentation, my presentation. Regarding the
Yes.
differential diagnosis, ischemic heart disease itself can cause aortic, يعني can cause valvular heart disease. In
Exactly.
general,
Yes.
يعني ischemic heart
Yeah.
disease is one of the most common causes of valvular heart disease. Regarding, I joined late, but regarding the performance of Dr. Ad, she's good, but I joined late at the end of the history.
Yeah.
My just notice, yes, she's okay, but she's used a lot of
Yeah.
this,
Yeah.
although she's good, although in
Yeah.
she needs to be more fluent
Mm-hmm.
with decrease that but
Yeah.
this it will affect the even regarding her safety netting. I noticed she asked about the driving, but she did not stop the patient from the driving, although the patient has chest pain. This is supposed
No,
to
no.
stop driving.
She asked him if the driving affecting, or the chest pain having effect on your driving. He said no. If he said yes, yes, supposed to stop him driving. But if
Uh-huh.
said no, I don't have this chest pain while driving, so what's the matter? It's okay. Okay.
Uh-huh.
To be honest, Dr. Bassem, when I asked the patient if he's able to avoid driving in the
Yeah.
meanwhile whilst
Yeah.
investigating him, he told me that yes, I can use buses. It's if I do have medical reason, it would be
Okay.
for
So
free. So
yeah,
this is
it's
what he
okay.
told me. This is what in the
Yeah.
real exam I just remembered right now.
Yeah.
Um, uh,
So the question, does the driving or does chest pain affecting you driving? You can stop him
yeah.
if he has just such issue. But if he doesn't have, okay, it's
Yeah.
safe to drive.
I'm sorry. I'm not saying this to oppose your
Yes, yes,
to
yes.
oppose your argument. It's just to what I
Yeah.
remembered something that has been told by the simulator when I gave the advice of the driving. He was fine with it,
Yeah.
and he
I got
added
your point.
this bit here.
Yeah, yeah. So he can have another alternative issue, which is riding a bus. It's okay. So
Yeah.
it's they have the flexibility to find a solution. They will not argue with you. What I want to say, they will not say, "Why, doctor? Why you want to stop me?" So he find another solution for you. Okay, doctor, I will ride a bus. Okay, thank you, Dr. Mahjoub, I think. Yeah, thank you for your comment. I think Dr. Ahad, as a performance, whenever she will practice more, she can overcome these problems. She will have the question in more fluent way. Maybe the way she's thinking what to ask, she is behaving like this. But I agree at the present time, whenever she practice more, she will be more perfect and professional. We
And
can start now. Yeah. Any other thing?
yeah, no,
Yes.
no. So it's just a comment about this. Even though myself, even I might sound
Yeah.
speaking
Yeah.
confidently
Yeah.
here on the
Yeah.
exam, you will be on your
Yes.
nerves. You
Exactly.
will be saying that I've said
Yeah.
that
Yeah.
I felt like I wasn't
Yeah.
performing as my usual. It happens. So Dr.
Yes.
Ahad, please don't feel low because of those comments.
Yeah.
It's just
I'm
to
so sorry, really,
add.
Dr. Ahad,
No,
if we commented on
No,
these
that's
things.
fine.
no,
Yeah.
because
Yeah,
this
But
no,
happened to me.
this is literally
yes,
my first practice.
really, to be
So,
honest.
I haven't prepared, to be honest, and literally I
No,
just
no,
prepared your case for
it's
today. So that's
it's
fine.
perfect. Yeah.
Yeah, it will come with the practice. I believe in that, so that's fine. Don't worry.
Yeah, it will be corrected, hopefully. Okay. Let's start now, Dr.
Shall we
Hassan. You
start?
ready?
Yeah.
Yes. Here you go.
Hi, Mr. John. I'm Omar, one of the doctors here in the unit. Can you just confirm your name and age for me, please?
Hi. My name is John Smith. I'm 30 years old.
Hi, Mr. John. I do understand that you came here today because you had some changes in your eye appearance. Is that right?
Yeah, that's correct.
So, could you please tell me more about it?
My wife has noticed that I have been
Okay.
having drooping of my eyelids, and when I just also like look in the mirror more, I just noticed the same thing. It's been there for a couple of months.
A couple of months.
Yeah,
Okay. Is it there all the time?
yeah, it's all the time
On one eye, on both eyes?
on both eyes.
On
Um,
both eyes.
yeah,
Mhm. You wanted to add something? Sorry?
no,
Oh, okay. And it's been there for the last 3 months, all the time. So, in the beginning of the day, how's your eyes?
it's been there all the time.
Okay. So no changes from beginning of the day or toward the late afternoon, for example. No,
No
no
change.
changes. Okay. And can you, how's your vision, given that your eyelid is drooping all the time? Can you see properly?
Yeah, apart from the eye dropping, it's okay. Yeah, it's okay. I don't have any problem with the vision.
Okay. And have you noticed anything that make your eyelids drooping more or anything you have tried to make it better?
No.
No. So beside your drooping of the eyelids, you didn't notice it yourself. You said your wife has noticed that. Um, uh, can I ask you any other, do you have any other problems other than that you think it's related?
What do you mean specifically by other problem?
Any other symptoms that you feel with for example, tiredness, fatigue?
Not really. No, no.
No. Any
Mm.
dizziness? You've said that you don't have any problems with the vision, so I assume that the drooping of eyelid is not covering your eye completely.
Yeah, yeah.
Any dizziness?
No dizziness.
Changes in your face?
In term of what?
Any changes you have noted in your face? This asymmetry, any weakness, numbness?
Okay, there is no numbness and there is no asymmetry. Weakness in my face per se. I can't relate that, but
Okay.
sometimes I feel some weakness in my hands and feet.
In your hands and your feet, okay.
Yeah,
Any other weakness in the other parts of your body other than the hands and the feet?
I haven't noticed, no.
No. So have you had anything just before the last couple of months as you have experienced this? Is there anything happened you can relate to that? How was your health before that?
Okay, my health was okay.
Okay. You are not taking any medications. You are not seeing any doctors
No,
for any chronic problems at all.
no,
You didn't have any infection or that or anything recently
I don't have an infection.
before everything started, I mean.
I don't have any infection. One thing that I can mention that I've been
Hmm.
having high blood sugar recently also.
Okay. Have you seen any doctors for that?
Yes. And at that stage, he just advised me to do exercise and to be more cautious about my diet.
Okay. And you are following the diet advice?
Yeah, as you know, it would be somehow difficult. You've been having like normal diet all your life, and then out of the blue, they just advise you to stick to specific type of diet. But
Yeah.
I'm trying.
So they didn't start you on any medication yet for your
Not
blood
yet.
pressure, for blood glucose. And you how do you monitor your blood glucose daily?
No, I'm not compliant with that, to be honest.
Okay. When
But
was the last visit?
my wife pushing me to do that every now and then, but I'm not very compliant with that.
Okay. When was the last visit to your doctors uh, for your diabetes or your blood glucose?
Okay, it just happened like 2 months ago, and I haven't had any visit after that.
Okay. Okay. Do you have any allergies?
No.
Any family history of similar problems or any problems in general?
My brother also noticed some drooping of his eyelids.
Okay. Have you had any diagnosis for that?
No, not yet.
Not yet.
He's been having
Okay.
also the same problem, like in the same period. He's younger than me, like 2 years younger.
Okay. And his problem started recently.
Yeah, it's very recently.
Okay. In terms of I'm coming back to your problem now. Other than the vision, you said that you don't have any dizziness, any visual problems, or but you've mentioned some weakness in your hand and feet. And those weakness, can you move your hand or your feet, or to what
Yeah,
extent this weaknesses?
yeah, I can move my hand and feet, but I've just like noticed some weakness in form of some problem in gripping things, but I've been able
Okay,
and managed to grip things still.
okay. And does it affect your walk, your ability to walk?
No, not really.
Okay. Have you noted any, do you have any fever,
No,
loss of weight,
no,
lumps and bumps in your body,
no,
change of appetite,
no,
any swelling in front of your neck,
no,
change in, like in the weather? Can you tolerate hot? Do you prefer hot or cold weather?
no. There is no other preference.
Okay. And do you have, what about your bowel habits?
It's okay.
Okay. And your waterworks?
My waterwork is okay.
Can I ask you what do you do for a living, Mr. John?
I'm a teacher.
And how's those symptoms has affected you daily living and your working ability?
So I think recently it's been affecting me to the extent that I just took some like sick leave until I can reach a diagnosis because this dose is increasing, to be honest.
Yeah, I do agree. We will provide you with necessary notes if you don't feel okay to go back to work. Do you drive?
Yes.
Uh, do you drive for a living? Like,
I'm sorry?
do you drive for a living?
Um,
I know that you are
no,
you are
it's just
working as a
like for
teacher, but
no,
okay.
it's just like for my like daily stuffs and activities. I just like go to the supermarket sometimes for
Okay.
visiting
I
others.
can I advise you for now not to drive until we um make a diagnosis about your problem and it will be controlled. Is that okay with you?
Okay, that's fine.
Okay. Have you traveled recently outside the country?
No,
No. And you don't smoke?
no,
What about alcohol?
I don't drink alcohol.
Okay. Before moving to the examination, do you have any concerns you would like to share with me?
I'm just wondering what I have.
Well, yeah, I will be answering this after the examination if you give me a little bit of your time. Can I start by examining you if you don't mind?
Yeah, that's okay.
Okay. I'll start by general examination. I will ask the patient to be honest to walk. First, can you walk toward the end of the room?
Um, yeah, he can walk,
Do you have any gait
but
problems?
there is some slowing of the walking. Mainly drive by his distal weakness.
Okay, what exact gait, please? Is it wide-based gait? Any gait
No,
problem
no,
you've
no specific
no
gaze.
gait.
No,
Okay. And tandem walking
it's okay.
and the I'll ask the patient to close his eyes and guard him. Is there any swaying?
No,
No, okay. Now I will start by examining the eyes. The drooping of eyelid is in both eyes, you've said.
yeah.
Okay. And then after the eyes, I will do the visual
Um,
acuity.
yeah.
Any
I'm just sending Dr. Basim a picture, but you can just proceed with the examination. Okay.
uh okay. Any change in the visual acuity, please?
No change.
Okay. And in eye movement in all directions, any diplopia, any double vision?
No diplopia, no double vision.
Okay. And the assessing the fifth and seventh cranial nerve,
Dr. Basim, I sent you okay. How could you assess the fifth and the seventh? What do
the
you like to do
sensation,
in these steps?
the sensation, and then asking the patient to raise the eyebrows, buff the face, any
Okay.
changes of the
So
face,
um w on the raising of the eyebrows there is a flattening. So there is features of the of seventh cranial nerve weakness or palsy.
okay, but no asymmetry of the
I
face.
have shared
There
the
is no
photo.
asymmetry. No.
Okay, and okay, and is there any changes with the 12s? And
Oh,
I will ask you to open the mouth and say, move the tongue to the side of the cheek. Is there any affection of
no
11th,
affection.
9th, and 10th cranial nerve? Okay. And for the hands, I'll do the tone. I'll examine the tone, the power, and the reflexes.
Okay. In the hand, there is distal weakness, there is hypotonium, and there is hyporeflexia.
Okay. And by now,
2 minutes
I
left.
will stop the examination. To be honest, I would like to complete my examination by examining doing a full examination of the lower limb and the rest of the systems. Well, Mr. John, from the examination, what I found is that there is some weakness in your face alongside with your eyelids. And you've mentioned that those symptoms has been there for 2 months, and your question was about what's happening with you.
Yeah.
Well, to be honest, I can't give a direct, straight answer to this, but it could be something that it's affecting some of the veins inside the brain or other possible causes. Therefore, I would like to admit you and to do some scans. Is that okay with you?
Okay.
I will speak with the neurology colleagues and to do further examination. Do you do you have any further questions or concern at this time?
Um, well, I thought that it's something running in family maybe because my brother has the same condition. What do you think?
Well, it could be, but other possible causes needs to be addressed also as well, after excluding dangerous causes first. Um, what have you had any headache
No headache.
recently? No
No.
headache.
Mm.
Okay. It can be a condition runs in the family, but we need to run this by the neurology doctors, and there is a possibility of other to be another problems that's affect. I think time's up.
Have you seen the image in the chat box?
Uh, no,
Can you just have a look, please?
but this image could have presented earlier if there's any image. I can't see the image. I'm sorry.
I said, Dr. Omar, I shared the photo. You didn't hear me.
Uh,
Okay, you can
No.
change.
I've mentioned in the examination that I
Okay.
send the image. If you can just have a look, please.
Okay, have a
Yes.
look here and we'll start discussion, okay?
Yes, but if you are talking to the patient from the beginning, you need to see the faces if it's relevant. Can you send Dr. Bassem? Can you send it to? I can't see it on the chat box. It's blurred. Oh, it's not loading. I meant.
I will resend it.
Okay. Bum, 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 bum.
You can see it clear now?
Have you seen it?
Oh, yes.
Okay.
Okay. Let's
We
start the
can
examiner
start
question.
discussion. Yes, please.
Okay.
Okay. Present your finding, please.
Well, today I've examined Mr. John, who is 30 years old, who came because his wife has noted that he has some changing in the eye. On assessment, on history taking, he said that both eyes are drooping, and this has been happening for the last 2 months. It's been there all the time. It didn't show any signs of fatigability from history taking. On examination, both eyes has been drooping, and there is some difficulty in raising eyebrows on both. I didn't assess the back of the eye, but there was no facial asymmetry on neurological examination. The rest of the cranial nerves were normal. He had hypotonia, as Dr. had mentioned, on the periphery and weakness on the periphery. There was problem. There was non-specific gait, but tandem walking was okay, and there was um, uh, um, pro no sensory deficit. I'm sorry, not what was the sign of the anyway, the rest of the examination, I didn't manage to complete at the time, so I would like to complete that by examining the rest of the systems. Um, from the time frame of the presenting problem, uh, given the fact that his family, and there is a family history of a similar problem, and there is a recent diagnosis of diabetes, this could have be muscular dystrophy problem for differential diagnosis.
Okay.
My main
Um,
would be myotonic dystrophy given the patient facies.
yeah. Okay. So what are the differential?
The rest of the differential of dystrophies would be Baker's and Baker's muscular dystrophy, facioscapulohumeral, but this is not in keeping with the patient appearance, and they usually tend to present younger in age.
Okay. Okay. Other differential?
As other possible differential would be venous thrombosis. Yeah, this is kind of what I can think of.
Okay. What form of workup you will do for this patient?
Investigating the patient, I would investigate the patient from the bedside, lying and standing blood pressure, capillary blood glucose, and urinary deb, moving to the ECG and X-ray, routine bloods, CK, and the specific investigation. For the specific investigation, I would do a nerve conduction and EMG, and then refer the patient for genetic testing, to be honest.
Okay.
And of course, imaging, brain imaging in form of CT or MRI if requested by the neurology team.
Okay. Would you think that this is something related to brain insult in the context of bilateral ptosis?
Not specifically, but I think his presentation more in keeping with muscular dystrophy, myotonia, dystrophica myotonia specifically.
Okay.
And
Yeah.
and I noted that his brother has not been formally diagnosed, so he can be moved to genetic counseling, and his brother needs tracing also.
Okay. Fine. How would you treat this patient?
In this patient will be treated in form of multidisciplinary approach. First of all, neurology input, genetic counseling, and genetic testing, diabetic nurse specialist input, and diabetic team. This patient is not following, he doesn't believe that his diabetes is well controlled and is not well monitored, so this needs addressing. He is driving at the time being, which he give an advice again is that given that the fact that his symptom could progress worse, we can refer him to physio and occupational therapist to provide him with the adjustment needed at home and at work.
Okay. Do you know any medication for myotonic dystrophy that can be given to the patient?
Myotonic dystrophy specific medication as a specific treatment? No, I don't think
Not
this
treatment,
condition.
but just to lessen the symptoms.
Not specifically, no.
Okay. Okay, that's fine. Yes.
Yes. Yeah, you can come in now, Dr. Ahad.
Yes.
I think you did well. You did well in the history. Starting from the analysis of the symptoms, you analyzed the symptoms well. You asked about other associated eye symptoms. I'm not sure if you ask about the diplopia. Are you seeing double vision? Because this is important symptoms. If you ask, that's okay. If you're not, you can just add it. You asked neurologically about the weakness, and you've excluded the myasthenia gravis. That's okay. Okay, there is some few question that you can add to your history. First of all, the patient is married, so if you can ask him if he's having kids, because myotonic dystrophy associated with testicular atrophy and infertility, and also the learning difficulties. Important symptoms in patient with myotonic dystrophy is bulbar symptoms. So you should ask about difficulty in speech, swallowing, or breathing. And also with the question of having kids, any difficulty in intimate relationship. I think these are the things that I noticed in the history, but these are very important. I'm not sure if you ask about any cardiopulmonary symptoms, because it's also important in this patient. So
No, I didn't ask. No.
yeah, so myotonic dystrophy can be associated with wide range of heart condition, okay, including heart block and heart failure. So you should ask about all the symptoms of the cardiopulmonary, okay, that we know. So these are the questions, but they are very important in muscular dystrophy that should be asked and should be excluded, because this will also give you very strong clue in the diagnosis if they are positive also. In the examination, you did well by examining. So obviously, you did examine the all the things for the vision, but I don't think that you need to do all the visual steps, since the patient is not having any visual affection. I mean, in this case, you need to examine many things. Okay, so this case examination include some eye examination, upper limb examination, hand examination, and some cranial nerve examination. So 5 or 6 minutes would not allow you to do all of these. Okay, so if you pick for the eye examination, for example, you can like start with the general inspection. Okay, you can do the visual acuity just to make sure that the patient is seeing well, and you can do the fatigability test. Okay, I think all the other thing could be offered regarding the visual examination. So after that, if the patient it depends, if the patient is having, for example, like some form of eye pain or ophthalmoplegia, you can just do the H shape. Okay, if the patient have very long standing eye, so fundoscopy will be offered in any way. Okay, so in the eye examination, the detailed eye examination with the other thing, this should be not doable. So as we said, some part of the eye examination, including the fatigability test, the visual acuity, and offering the fundoscopy, and very important part of the eye examination is examination of the cataract by torch, and this should be excluded also in the history. If you have any if you should ask the patient if he's having any eye surgery before, okay, or a condition called cataract. Then hand examination, which I think you haven't done in this case, and this is very important. This is one of the most important thing to diagnose myotonic dystrophy. So looking for the hand, any wasting, okay, grip myotonia, percussion myotonia. This is very vital part of the examination of patient with myotonic dystrophy. You did the upper limb examination, very very important part of the examination. And I heard one examiner, one of the mentor before, mentioned that the candidate has been got mark for not examining the pulse, and the examiner commented that the candidate has examined the pulse and the patient has AF, because a myotonic dystrophy is associated with AF part also. So checking the pulse. You've checked for the seventh cranial nerve. Okay, you can just like pick any like two of the muscle examination. Okay, you did the frontalis. You ask the patient to look up like upward. You can do for example, and you also check for the vaccinator. Very important part of the examination. You've mentioned that, but you haven't mentioned the way that you're doing that, because it's important for the fifth cranial nerve examination. Okay, so examine for the muscle wasting. Okay, you can examine for the temporalis by putting your hand in the temporal area and ask the patient to clench his teeth. Okay. And you've examined, I think, for the neck for any goiter or swelling. Yeah. Just offering to examine the genitalia because of the testicular atrophy. This should only be offered. This is regarding the examination. So very important parts shouldn't be forgotten. I think I think this is a spot diagnosis.
Yes,
there is a
this
differential.
this is why I would appreciate it, because you I would comment later on, Dr. Ahad. Please continue. I'm sorry.
This is a spot diagnosis. From the beginning, it's very obvious with the patient with the bilateral ptosis, positive family history, diabetes, and I could have mentioned the infertility if you ask me if I'm having kids. And I will mention that I've been having problem having kids for a long time. So it's spot diagnosis. I don't know why you mentioned to the patient that he's been having some problem in his veins of the brain.
Because that spot diagnosis means you recognize the symptom by seeing the patient. So if you see the facies, you would think of that in the very beginning. So because in the history, I don't think we are taking history from a patient behind a curtain. So you would see the patient, you would pick the facies if there is anything apparent. So this is what throw me off away, to be honest.
Okay.
And I didn't see a picture now. Yeah. Please continue.
I appreciate that the picture has been sent late. I sent it during the examination, but I think even if you haven't seen the picture, you've been having like specific diagnosis for ptosis, with the patient having like these specific symptoms, bilateral ptosis with a positive family history on diabetes. And in the examination, if you examine the hand, I will give you all the positive findings in the myotonic dystrophy. So I think I'm not saying that you should spot the diagnosis even without seeing the patient face, because this is an important. I appreciate that has been sent late, but this shouldn't putting the dystrophic myotonia up like away from the diagnosis. It should be also kept in the first differential diagnosis. And if you are not sure also of the diagnosis, I think because if you are not sure of myotonic dystrophy, you've been putting the muscular dystrophies in general in your mind. So I think if you can also give this patient information in general, that you've been having like muscle weakness that is running in family, but I'm not sure about the exact diagnosis of this muscle weakness, but it's something like running in family, and we need to investigate behind that rather than diverting to diagnosis of like brain insult. So I think in the concern, I've been having a concern also, but I think the time has been very limited that if I will be having a kids or no. And yeah, the question is there is a chance, but the chance is low compared to the population, but we can refer you to the fertility clinic. This is regarding the patient the history examination and the patient concern. Regarding the investigations, you did well regarding the investigations. The EMG nerve conduction study, I don't think it's related here. So basic investigation, EMG, CK, as you've mentioned, genetic testing, for the heart, if the patient investigation for the complication, if the patient has any complication from the heart, like from the heart condition associated with myotonia dystrophy. So you can do echo, ECG. I think also important part of the if you got time for the heart in the examination, you can just like listen for any like biphasic crackles, or see if there is any lower limb edema as a heart failure associated with this condition. Annual eye examination for the cataract is a screening test. And I think you've mentioned the diabetes workup, and also you can add hormonal profile for the hypogonadism. The treatment, as you've mentioned, you did very well, the multidisciplinary team. The medication I ask you about is sodium channel blocker, like phenytoin or mexilidine. So it can help with the symptoms of myotonia dystrophy. I think this is my comment regarding the case. Thank you. Well done.
Thank you,
Yeah.
Dr. Ahad.
Okay,
And
thank
you
you,
would
Dr.
ask
Ahad.
Dr. Basim if
Thank
he's
you, Dr. Ahad.
Thank you, Dr. Ahad. You want to ask anything, Dr. Omar, before I comment?
No, it's just the only thing that's in reality on the exam you will be seeing the patient. This is if and then the stem wouldn't be that short, to be honest, from personal experience. The stem would be full of information about this is also to waste your time, but you would take a grab of the things before you're going to see the patient. But I think myotonic dystrophy would be, you would recognize it from seeing the patient straight away. You would think so to organize the examination. So I think I've get that late after the examination has been finished. Like, so this is maybe why I
It's
didn't
okay.
think of it as a first thing.
Yeah, it's okay. But let me correct this idea, Dr. Omar. You can ask the examiner if he can allow you to see the patient for a while, then you can go back to take history. Either, particularly if you have spot diagnosis suspicious. For example, the skin rash. Always the advice whenever you have skin rash presentation or complaint, ask the examiner, I want to see the patient. Whenever you see the rash, you can know the case and you can narrow your differential.
No.
Here as well, you can ask, can I see the patient? In order also to narrow your differential. If you suspect something, it can be diagnosed with spot. Okay. But what's important if you cannot see the patient or if you didn't see the patient? What's important in the history taking? You ask about the nature of the eye. What do you mean by change of the vision or change of the eye look, right?
Yes.
So this is the magic question. What do you think about the vision or your husband or what your wife noticed? What she mean by the appearance? He will tell you my eyelid is dropping. diplopia or whatever. Okay, so this is will be added to onset course duration. I think you covered this part. Diplopia, I think also you asked because Dr. Ahad said you didn't ask about diplopia, right?
Yeah.
You asked
No,
about?
I have asked. I've
Yeah,
asked
so
about
it's
any change of vision, any double vision,
perfect.
any visual blurring of vision, and then yeah,
Yeah,
probably
perfect. So
yeah, you can
whenever you
correct
have
me if I
whenever you have any eye affection, you have to ask about vision affection. Not only vision, the color, the red, the night, or double, or pain, all the things will affect your diagnosis. I want to say here also as a case, it's like a clue, very clear clue for your case to say it could be myotonia dystrophica. Whenever the patient is telling you, I cannot grip the things, it's really
yeah.
pathognomonic for myotonia dystrophica. I cannot grip the things, so I cannot open the jam. All this can say, or you can suspect myotonia in top of your differential. This is type
Yeah.
1 of myotonia, which is distal one. So you can diagnose it from this word, adding to the other finding. The most important here to roll out as a first differential after myotonia will be myasthenia gravis. The timing of the weakness. Is it something on and off, not related to the evening time or at the end of the day? So it's not myasthenia. If yes, this is myasthenia. And always, whenever you examine for myotonia, roll out myasthenia because they are very similar. Don't forget to do the proximal myopathy examination as well as the distal. You have to differentiate, is it distal or proximal or both? Okay. Whenever you have any neurological, you have to ask about the other neurological manifestation, the hearing, the smelling, the facial look, which you ask already, facial asymmetry. It's very important to ask. Are you able to close your eyes if you want to say this is facial nerve palsy? If not, so it's not. Okay.
Mhm.
Yeah, diabetes complication. Briefly, you have to ask how is your diabetic control, what medication, and you can ask the other question for hyper or hypoglycemia whenever you are screening for systemic review. The driving here addressed by you, which is perfect. Why? Because not only eye affection, the ptosis, even the vision itself,
Weakness. Yeah,
the
the weakness also.
weakness, plus the vision itself. This patient might have cataract and he might have diabetic retinopathy. So you have three reasons you have to stop driving for the weakness or ptosis, okay, and the cataract, and the third will be diabetic retinopathy. That's why you have to offer fundoscopy. I disagree for Dr. Ahad comment. Should I examine the all eye examination? Yes, you have to examine.
Yes.
So all examination you have to offer, even you can do it fast, but you have to examine acuity fields and reflexes, as well as for fundoscopy. As I said, you can find retinopathy. The cataract, you can do torch examination for the red reflex. And the H shape, here you have to do the H shape. Is there any weakness or diplopia? Okay,
I
you have
did. I
to.
asked for the
Yeah, I'm saying
oh,
because she said no need to do the all detailed eye examination.
no.
I'm correcting that. It's crucial to examine the eye from all point of view of visual examination or vision or eye examination. It's not only
Diplopia, yeah,
yeah,
eye presentation in the PACES equal cranial nerve examination. This
yes,
is a
exactly.
must. All cranial nerves need to be assessed.
It's not all cranial nerve. You cannot cover all
At
cranial
least,
nerve.
yeah.
At least the seventh, who can or which you can localize the lesion from it. The
Yeah.
seventh or the hyoglossus.
Sixth, yeah.
Six and trigeminal you can offer, but six already you are doing in the H shape,
In
by
the
the
H
way.
shaped, yeah.
Yeah. So at least do these cranial nerves. Let's go back to the hand examination, tone, power, reflex, coordination, sensation. All of them you have to do. Why? You have diabetic patient. You have to rule out the
Diabetic peripheral neuropathy.
neuropathy. You prefer neuropathy, yes. The pulse is important, yes. Some patient of myotonia, they have heart affection, so they might have a block, AV block. So you have to examine here. You have to examine even for pacemaker. The chest, not all examination, inspection and cardiac exam for apex. If you have other time for time also for other time for other diabetic finding like peripheral neuropathy in the leg, you can do the gait you did. It's perfect. Some patient will have peripheral neuropathy, or the gait itself as myotonic gait. The patient will have waddling gait. Okay, if he
Mhm.
has paroxysmal myopathy. The other differential of dystrophy you have to mention, yes, as you said, limb girdle, but limb girdle will not affect the fascia. The fascia. So the first case, the first differential of our case, myotonia. The second will be myasthenia. The third will be facioscapulohumeral dystrophy, because also it can affect the facial appearance. However, it's not affecting the vision itself. Okay. What else I want to add here? The driving, it's very important. No need to ask, is it for life or just driving? Any type of driving here, you have to stop. Okay, not in detail. So, driving for own car or heavy vehicle, both of them, he should stop. About duration, if he asks you, doctor, for how long, now you can ask what type of driving you are doing. Okay, in order not to waste time for this question.
Yeah.
Family history here very important. I think also you ask, right?
Yes.
Yeah, myotonia dystrophica is inherited condition, runs in the mood of.
Autosomal dominant.
Yeah, so you have to. There is two types, as you know. First type is distal. The second one is proximal one. The first type is the gene is DMPK, right? And
Yes.
the second one
NF9.
ZN9, yes.
ZNF9.
NF, yeah, ZNF9, yes. The management, Dr. had already mentioned. The investigation, don't forget the genetic. And
I
this is
mentioned the
specific.
genetic, did I? I
Yeah, yeah,
mentioned
yeah,
that, yeah.
yeah. I agree you do also, but I'm
Uh,
just repeating for others as a revision to the topic.
no,
The
I just
management,
forgot, yeah.
yeah, the management always multidisciplinary. Whenever you have multi-system, multidisciplinary. Physiotherapist is a must in any patient with weakness. Don't forget the physiotherapy, limb, and occupational therapist. Some patient needs more aids to cope with the life. Okay. Yes, I am done with my comment. So Dr. Omar will say he did perfect. Apart from the face of the patient, whenever you have the face, you
Yeah.
can know the case. So it's okay. Don't forget to mention long haggard face or
Yeah,
wasting.
haggard face. Yeah.
Yes.
It's
Okay.
myotonic fascias. So
Exactly.
I don't know
Yes.
here, to be honest, Dr. Bassem, I don't know if Dr. Ahad is working here or abroad. I
Mm.
meant in the UK. So usually I know that the overseas exams might be a little bit different from UK exams, but
Yeah, you're
in the
right.
UK exams, if they are if something that it is spot diagnosis and the patient is not able to come, for example, they don't replace it with surrogate, they will change the scenario. So
So
you
you have the
won't be
patient
seeing,
himself.
yeah, if there is if the patient is if the presentation is with something like spot diagnosis, you can look for example, a patient who have like myotonic dystrophy or thyroid goiter or something. They won't do a surrogate type of scenario. They would change the stem or the scenario at all, the whole.
Yeah,
So you, when I might understand that overseas you might be talking to a surrogate and the patient is
yes, yes.
lying on the bed. So it is not the
Exactly.
case here.
Yes.
So this is why I was expecting from the beginning to see the patient. So it is might not be. It might be a difference in expectation. That's it. So
Yes,
this
thank
is
you
what
for
this
this
is the
note. It's
comment.
important.
Yeah.
Yes, you're right. We are in the overseas, as you said. Sometimes most of the center they have maybe some of them educated, but not all of them educated surrogate. So you can talk to the surrogate who's working as a doctor or nurse
Hmm.
in the center, and the patient will be hidden or behind the curtain, or sometimes some educated patients they can talk to you, but they are not professional as well. So you don't have the optimum in both, either surrogate with a patient hidden, or
Yeah.
candidate or the patient himself who's not well professional that because he's not a doctor, he might be another profession, so it's not optimum. Anyway, what I want to say, in both condition, you can ask to see the patient either, or to see the rash itself, or to see the area of trauma, or to see the swelling if you are suspecting something and you want to narrow your differential.
Yeah.
This is the aim of our point. Yes. You
Yeah,
want
yeah.
anything else?
No, but I'm not aware of the sodium channel. The Dr. Ahad, it's the first time I've heard about this
No, no, it's one of.
medication. Can you? No, no, it's for my information, so I can add it. What's the name of that medication?
It's one of the medication that can help with the symptoms of myotonic dystrophy. So it's a sodium channel blocker. So, for example, phenytoin or mexiladine.
Mm-hmm.
Yeah,
Phenytoin.
it's not curative one. It's
Yeah,
just
it's controlling the
supportive.
symptoms.
Yeah.
I would like to add one thing, Dr. Basim.
Yes.
I
Sure.
think th- th- I think yeah, this is my opinion. I think the eye examination, all the eye examination in this station wouldn't be very beneficial. So if you're doing like visual field for patient with ptosis and you're thinking like 90% of myotonic dystrophy, this wouldn't help you much. Reflexes, so reflexes, by any mean you will do like torch for the cataract, but I mean, rest of the reflexes, like visual field for this patient, he's not having any vision affection. So to like my thinking is you should concentrate on specific thing for this examination. Firstly, to confirm your diagnosis. Secondly, to exclude the other differential, which is mainly here the myasthenia gravis. So I think in this patient, if the patient has been having a vision affection, like any, so I will start with the visual acuity, and from the symptoms also, from the history taking, if the patient has any vision affection, and also if I did the visual acuity, which I will do in the beginning, if the patient's any problem in this, I will proceed further with the eye examination, like doing the visual field, doing the other things like reflexes. But if the patient is not having any visual symptoms, if the patient's visual acuity is okay, I wouldn't waste my time on doing the full eye examination, and I have upper limb examination, hand examination, some heart examination, cranial nerve examination. So this wouldn't be doable in 6 minutes, to be honest.
Okay.
Um,
Uh,
so
let's let's clarify it, Dr. Ad. If you have, as you said, acuity affection, so I might go with the red reflex for cataract, right? The field, I can remove it from the examination, as you said, because whenever I'm okay with the vision, yeah, the field itself, it will take more time. So yeah, I agree to remove the field from the examination, but the H shape here is a must. H shape, because you have weakness, means you have to rule out which and what type of muscle affected in this patient.
Yes.
So the H
Yes.
shape, yeah, is a must, but maybe you can remove the field examination if the acuity are okay. Whenever you have acute affection, you can check for the field, and you can check also for the torch or the reflex, so you can rule out cataract as red reflex if the red reflex is absent. You got it?
mm,
Yeah, but yes, you're right. You can remove these things, but its shape, I think here is a must. You are talking about weakness, so how can I judge on the weakness or the power of the muscle without doing the its shape? And you ask also, you said one of the question I should ask about is diplopia. So how
Yes.
to confirm the diplopia here?
Um,
yeah, and one of the differential is third corneal nerve. Yeah.
Exactly. So yeah, I think our other you might remove, but the H shape is a must. If you have time, you can do all of them. If you don't have time and you can focus, you want to focus on the power and the legs or the arms examination, okay, you can postpone these things. But the H shape here is a must. You have to do it. Sorry. because it will give you the idea about the strength of the muscle, the extraocular muscle. Okay?
Yeah, I agree with H also. Yeah.
So
that
in
Yeah.
makes
this patient, when you're examining the tone and holding the hand of the patient would have a slow release.
Yeah.
This would be also another
Yes.
symptom, which I don't think has been mentioned. So when you examine the tone, you would shake the patient hand and
No.
Yeah, I
in
mentioned
a
that in the
grip
grip
way.
myotonia. Yeah. So in the
No,
hand,
I got your
No,
point,
I
the
Dr.
didn't
hand
hear.
three things.
I
Omar.
didn't hear it, to be honest. I didn't hear
Yeah,
it. Maybe it's because of my side problem,
yeah.
but
So in the hand, the three most important things in myotonic dystrophy is wasting, grip myotonia, and percussion myotonia. So this is the
yes, but
three main thing in
No,
myotonic.
I want to clarify the point, Dr. Ahad. Dr. Omar is saying whenever I examine the tone, you should mention to him the grip or the grip is positive or the myotonia grip is positive. I'm saying no, it's not a must. You have to do
not
it
a
as
must.
a specific. Yes.
So
Yeah,
when you're asking when you are holding the hand of the patient, you wouldn't notice that it's a slow
No.
release. So no.
so if you Dr. Omar, if you examine the hand of the patient for neurologically, this is yeah, so the patient is not gripping or holding your hand. So you're just like doing the hand
Yes.
examination with the hand relaxed. So you couldn't assess the grip myotonia. But the
Yes.
grip myotonia, if you would like to examine it specifically, you should ask the patient to grip your fingers.
Exactly.
So you will see
So
the
in the motor, you would ask the patient to make a fist and cock his wrist back. And to make a fist, you would asking the patient to you would notice the slow release at this stage. Um, uh,
Okay.
uh, this is how I do the
Yes.
motor. Yes, I didn't mention it in my, but this is on my way. I didn't mention it. I didn't phrase it. But so this is might be
Okay.
uh,
Let
why
me
I was
answer this
explaining
part.
that.
Okay.
Yeah.
Whenever you do the power, yes, you are asking the patient to hold your hand. But if you are not putting the differential as a myotonia, you will not notice that he has slow hand release. You got my point. Yeah, I think you will not notice it unless you focus on it.
Yes. So I think usually in myotonia, the the patient, not all the time he does have the this is what you're trying to say, Dr. Bassem, is it,
Grip?
or Dr. Ahad, is it the grip? You wouldn't notice it from other, or you can't comment on it from other examination unless you've examined
Steps.
for it specifically.
Yeah, what I mean, the stress itself. Your stress, maybe you will not notice the
Mm-hmm.
finding of hand grip when you do it, and not as a voluntary test, or you do it as power test. You will not notice
Mm-hmm.
that the grip is slowly released unless you focus and you do it as a test, specific test. I want to do the hand grip itself, so I will hold my hand and release them. You will notice that the release is slow. But if you do the motor and you ask him, hold my finger, yes, it can give you a hint. But if you are not focusing on this part, you might forget it because of stress, not because of the patient, because of the stress. Okay, you will not notice that it's slow unless you focus on this part. You got my point?
Mm-hmm. Mm-hmm.
I think if you just like train yourself to do
Mm-hmm.
this grip myotonia as part of the hand examination from the beginning, just not to avoid to forget this in the neurological examination, because in the neurological examination you're just focusing on a specific thing that wouldn't be changed in examination of myotonic dystrophy. So if you keep it separate as myotonic dystrophy, I need to do three things in the hand in the beginning, okay, just to confirm or to give myself clue, and then do the separate your neurological examination as one thing. So,
Okay. Let's
and
Okay.
you
make it
need
more
also to
clear,
show the
Dr. Omar.
examiner that you're doing the grip myotonia. So this
Okay.
should be done separately. Yeah.
Okay, let's do it in another way. Whenever you will see his face, you will know this is myotonia dystrophy
Yes.
case. So I will do this test. Okay,
Yeah,
not the opposite. I will
it's
not do
like
this test, yeah,
yeah,
before seeing his face.
it's like the Parkinson's. When you enter the
Exactly.
cubicle, you would recognize that the patient have resting tremor, so you know
Tremor.
that you are doing
Exactly.
the
The,
hypomania. You will ask the patient to write, and the specific examinations. Not you will not be
exactly.
diving in
Right.
the whole neurological examination. This is what I
Yes.
wanted to say from the beginning, is that
Yes.
if you saw the patient from the beginning, because you are entering the cubicle,
Exactly.
speaking to the patient, you would know. This is what I
Y- y-
it will be helpful.
Absolutely right.
Yeah.
Whenever you will see his face, you will know this is a case of myotonia. I should do the test of myotonia. But don't
Mm.
forget to do the fatigability test to rule out myasthenia, okay? Because
Yes,
myasthenia also might
is
look
the second
the same.
differential. Is the
Yes.
second differential. I do agree.
Yes.
And
Yes.
this is why I asked for a recent infection or any
Perfect.
changes before the symptoms, but because I thought it was myasthenia in the very beginning, then I no, from the scenario from the history, I
Perfect.
excluded that. Yeah,
Perfect. Perfect.
it
Okay.
was a very
Thank you.
nice case, Dr. Ahad. Yeah.
Yes, it's nice case. Both cases really today were nice. Any question or comment, Dr. Ahad or Dr. Omar?
No, so to summarize the myotonia specific examination, you recognize from the beginning that this is a case of myotonia. So you would shake the patient, do the myotonia specific hand test first, then ask the patient to walk, then do the rest of the neurological examination, which will be mainly in cranial nerves, not all of them, but importantly the eye, visual acuity, the head shape movement. If you have time to do the visual field, it's fine, but you need to examine the heart, at least by
Perfect.
listening, by doing the auscultation at least, and the palpation of the apex to rule out the
And an
direct
inspection for a
cardiomyopathy.
scar for a pacemaker. Okay.
Yeah, the patient will be you will ask the patient to take off
Yeah.
the
Yes.
shirt.
Yeah.
The other thing in the management, that you need to have a baseline echo. This is to be added
ECG.
to my
ECG as well.
yeah, ECG is on the bedside. We are
Yes.
we are
Exactly.
fixing this is at least myself. I'm fixing the examining the patient is
Yes.
from the bedside, bloods and specific investigations. Uh,
Genetic. Yes. EMG,
the
not
nerve.
nerve induction.
I mentioned both nerve conduction and EMG because EMG is the diagnostic, but you don't yet you don't have a full diagnosis yet, given the patient has diabetes. So I offered the why this is why I offered the nerve conduction also. Uh,
Okay, you can mention
um,
this one.
uh, as peripheral neuropathy, but it's for the exam purposes. In real life, you won't be mentioning that. It's
Exactly.
yeah.
Even the differential myasthenia also diagnosed with EMG.
The EMG is the
Yeah.
diagnostic, yes. It's
Exactly.
the
Yes.
diagnostic clinical, but it's the main diagnostic is genetic testing, but
Specific. Specific one.
the specific diagnostic
Yeah.
and the management, you will add the cardiology or at least an echo to your management, and start referring the patient early to have a baseline cardiac performance investigation by the cardiology team.
Yes, exactly. Okay. Thank you, Dr. Omar. Again, you summarized the case in 2 minutes. Dr. Ahad, you want to add anything or to ask?
No, thank you.
Okay, thank you, Dr. Ahad.
Thanks.
Well done as a first time, but keep going, practice more and more. I will read the comment quickly, Dr. Ashima. But why the complaint developed recently? Division, you mean? Because all with the weakness, those people that with the dystrophy, they have the onset will be like this insidious onset. So you cannot say he's manifested, but with the time, with the aging, he might have this weakness more obvious and apparent.
Expressivity of the
So
expression.
there is just to add in the myotonic dystrophy, you can have like spectrum of range of time for
Yes.
the symptom onset. So some patient will be developing the symptoms since childhood, and other patient can be diagnosed until like 30s or until 40. So the symptoms shouldn't like it's not the must that the patient have the symptoms in the childhood or is born with the symptoms. So you can have patient with myotonic dystrophy that has been diagnosed at the 30 or even 40. So this shouldn't direct you away from the diagnosis, even if it's
Yes.
congenital or
Yes, you're
I
right.
mean hereditary.
You're right. Diabetes in both condition might be associated, but as a myotonia, it can be associated as association, and also for myasthenia, it might be associated as autoimmune. So don't be distracted by diabetes. Both of them can have diabetes as association, and it will be a clue, not as a distractor. Okay. Any other comment or question from Dr.
So
Omar?
the dystrophia differential diagnosis as per the incidence of them is Duchenne and Baker both are X-linked. Dystrophica myotonia and facioscapulohumeral are both autosomal dominant, and limb girdle is autosomal recessive.
Perfect.
All of them present in younger patient
Limb
age.
girdle is autosomal dominant.
It's I think it's recessive, but I will check that. But if it's dominant, then I might be mistaken. Sorry for that.
No,
Uh,
no,
all,
no.
all of them are presenting in childhood, except for myotonic dystrophy can present later.
Mhm.
And then there is other differential. This is if you asked about the differential, if the patient is presenting with diplopia or a visual symptom, as in this case, you can be having the myasthenia. And of course, if it's an acute presentation, you can add botulinum toxin, botulism to your differential, if in case of bilateral diplopia, and also um, uh, the autoimmune condition, what's called, it's
Yes.
demyelinating.
Yes.
Do you remember it, Dr. Bassem? It presents with diplopia. One second. I forgot this.
By the way, limb girdle have both types, recessive, autosomal recessive, and
Yeah.
also dominant. I have checked now. Okay.
Yes. The what I meant to say is the to add to this differential. Um,
Guillain-Barré, you want to say?
yeah, Gambri. Yeah, Gambri. If the presentation is with ocular symptom mainly, you can, if you've asked what else other than the muscular dystrophies you would like to add, then yes, myasthenia is the second, and if it's acute, you can mention the Guillain-Barré and or the
Yeah, Miller-Fisher in particular.
yeah.
I don't think Miller-Fisher could be differential here since the patient is not having any other like there is non-triad of Miller-Fisher. Um, I would say in this case specifically, the first differential should be myotonic dystrophy. The second differential, as you've mentioned, any other muscular dystrophy like Baker mainly, and the third differential I will put myasthenia gravis. But again, it's sad that it's not fatigable weakness. Um, so I think this should be
You can
only.
replace Baker
Mhm.
by facioscapulohumeral because there is a facial affection.
Yes.
Yeah, all the muscular dystrophy, mainly including Baker, you can add.
So it's from the
But the third will be myasthenia gravis. I think if the patient has any other symptoms of maybe if the patient has gait affection or something like that, you can add Miller-Fisher.
Okay.
uh, So
Anything else? Yeah.
the dystrophies are Duchenne, Baker, dystrophica myotonia, facioscapulohumeral, limb girdle. So they are both in the same category. So the first and second differential are both dystrophic, myotonic dystrophies. The second differential I would give is the myasthenia as from a group of the diseases outside of the myotonias. Why is that? Because the presenting complaint is visual and in form of bilateral drooping. So this is logical in the differential, and the Guillain-Barré, if it is in acute following a recent illness, then you can add it. Yes, if this is, I hope that I'm making sense in
Yeah, it
the way
makes
I'm
sense, but
explaining.
they
Yeah,
will not ask for more than 3 differential.
yeah.
I think
Unless
if
you
you
give
if
it.
you
It's
if
just
you
it's just
even
for our revision. Yeah.
if you
Yeah,
even
yeah.
separate it, that should be fine. If you mention the myotonic dystrophy in the first differential, and you mention any other like muscular dystrophy like Becker dystrophy in the second differential, and you put myasthenia in the third differential, that would be fine. But I think in my opinion, Miller Fisher wouldn't be suitable differential here, since you only have doses without
I
any
didn't mention Miller Fisher
effects. Yeah.
um,
So
in my
if we
question.
mention Guillain-Barré, so
Guillain-Barré,
Miller Fisher, the thing that
Miller Fisher is different than Guillain-Barré.
yeah. So
It's a
Guillain-Barré is
variant of Guillain-Barré variant.
Yes, it's a variant.
it's variant of Guillain-Barré, and this is
Affecting the
the
muscle
variant
occlusion
that can come
of
with
the eye
vision
vision
symptoms.
more than
Yeah. So Guillain-Barré
ophthalmic lesion.
normally doesn't
Yeah,
present with
it can have
bilateral dosage.
ophthalmic lesion.
Yeah, of course, yeah.
Okay, I want to add one comment for Dr. Ahad case, the first case, Dr. Ahad. Sorry, I forgot to mention it, but it's very important. And thanks to remember it when you mention the acid brush or acid test while talking in this scenario. Whenever you have chest pain, you have to roll out the GERD, okay? Because the GERD sometimes it can present with chest pain.
Yeah.
And yeah, whenever you have it, you have to ask about any feeling taste or acid taste in your mouth. You show the examiner that
Yeah.
you rolled it out, and even you can put it one of your differential. GERD can be presented in the same way of chest pain. Sometimes chest pain presented with epigastric pain, which is similar to GERD. So please put it in your approach for any chest
Esophageal
pain.
dysmotilities in general.
Yeah, any chest pain, you have to rule out the GERD as a differential or as a cause. Okay?
Yeah, they should have been excluded, to be honest. Yeah.
Yes.
Thank you,
Yes.
Dr. Bassam.
Okay, thank you, Dr. Ahad. Thank you, Dr. Omar, as well. Thank you,
Thank
everyone.
you.
Anyone want to add any question or comment before ending the session? It's fatty session with two nice scenarios with good discussion. I hope all of you get the benefit, particular Dr. Omar and Dr. Ahad. If no question, we can end the session now. So we can
Yes.
wish you good luck and good night. Thank you, everyone.
Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum salam. Thank you.
Thank you too.